I'm Dr. Peter Nakaji, neurosurgeon, very interested in Chiari malformation. It's a condition I've treated for my whole career in life, and I'm very passionate about the way that it's treated. And I get a lot of questions from people about Chiari malformation. How is it treated? Why do you treat it the way that you do? And what can I expect? And I think the more information you have, the better. So what follows here is all just a series of observations, questions, and answers about things that you should know about Chiari surgery. So for Chiari malformation, there is unfortunately not much you can do other than surgery to fix the problem. That's because either the skull is too tight or the brain is too much. You can't fix that problem other than fixing it. There's no way to shrink the brain without surgery. There's no way to expand the skull without surgery. It doesn't mean everybody goes to surgery. Some people, symptoms are not that bad. Some people don't actually have symptoms. We just find it by chance. But people who are symptomatic, if it becomes a significant imposition on lifestyle, if the headaches are really bothering you, if the other symptoms are really bothering you, or if fluid is building up in your spinal cord to a significant degree, then surgery would be necessary. And then the question is simply what surgery to do. In terms of what surgery to do, the opening is made at the back of the head, usually just above the hairline, sometimes one fingertip below. And through our way, which is the minimally invasive way, we just use a very small incision. You may see some much larger incisions described, but effectively, we're doing the same surgery or more through the smaller incision. And you need to go down, expand that space where the skull is too tight, take off the back arch of the first cervical vertebra. That's one of the bones of your neck. That does not affect the stability of the neck, fortunately. The stability comes from other things. And so then we go inside, and then you usually check to see if flow has been restored of spinal fluid. Sometimes it has been just by taking off the bone and the soft tissue band. Sometimes we see that it's not enough and we have to open that covering and sew a little patch in. And the patch basically expands the space and allows spinal fluid to pass through freely. It's probably a little oversimplistic to say that just restoring spinal fluid flow is the whole cure for the problem. But for most patients, I think you can think that that's the main thing. Sometimes we do have to go in and shrink a little part of the brain that's sort of in that plug. That isn't a thinking part of the brain. It's been done for many years, and you suffer no ill effects from that if it needs to be done. It can promote scarring in some people, so we're very cautious about how we do it in a kind of a no-scar technique. And also we don't overdo it, meaning that we just want to do as much as is necessary to get that flow restored so that for the most part, it's your normal anatomy. There may be little spider web-like bands inside. We free all that up too. Again, if the fluid can get in and out freely, with every heartbeat, with every breath, whenever you strain, most people are going to feel great again. So a good decompression surgery is one that is the right one for you. I think that's really important because it's not one size fits all. If someone says, I always do blank, probably you should have something that's specific to you because there are a lot of ways to do this. But the main thing is that there should be good bone removal, which is wide enough that it goes beyond the edge of the tonsil, so not just a narrow bone removal. You want to have the arch of C1 is removed in most places. That's the first cervical vertebra because that's part of where the compression is for most people. And then that there's an adequate decompression, which could mean opening the dura, which is the covering of the brain. It could mean not opening the dura because, when you open the dura, there is usually more nausea, the surgery is a little longer, recovery can be a little slower, the risk of spinal fluid leak is a little higher. On the other hand, for people who need that flow, a good surgery involves opening that up and creating enough room. And so that's really the name of the game. If it restores flow, that's good. Now, beyond that, being very meticulous about technique so that we handle all the neck muscles kindly, that we're really, careful about it. And in my view, that you don't shave the head, we just braid the hair out of the way or pull the hair out of the way and then have a really plastic surgery closure because there's no reason to leave a big dramatic scar for this kind of thing. I've done these surgeries for decades and I can promise that the smaller incision where a lot of work happens inside is just as effective, probably more effective, and doesn't require all that trauma and definitely leads to a faster recovery. So this is a question I get asked all the time. Do I need a patch? Do I need a duroplasty? So the dura is this leathery case that holds in the spinal fluid around the brain. And that is often part of the problem, is that it's too funnel-like. and too tight. And so sometimes we find that we have to open it and then make more room. So imagine that you have anything that's just, like a piece of fabric pulled too tight around a cylinder. We would cut that fabric, sew a patch in it, and now it would be all loose. So that's what we're trying to achieve. I usually assess that with ultrasound during surgery. I can see the brain moving inside. I can see the spinal fluid flowing. If it's flowing beautifully without the patch, I really recommend that you don't patch. You don't need to have a gigantic patch in every case. Maybe for the same reason that if your belt is too tight, you just have to loosen your belt. You don't have to take it off. And it's the same thing. Just enough opening is really all you need. But for some patients, they're not going to achieve that unless we open up that covering, make sure nothing else is adhesed or stuck together, and then put this patch in. And the patch is usually a synthetic patch of a kind of a collagen. It gets absorbed by the body and turned back into normal dura. When you go later, sometimes you find the tiny stitches, but the patch itself looks just like the rest of the brain covering always does. Yeah, it's a great question that people worry about is, can symptoms come back? And the answer is, it depends. For the vast majority of patients, they do not come back. For the vast majority of patients, one Chiari surgery is all they'll ever need, and it will take care of the problem. Occasionally, we see patients who have secondary Chiari and we don't know it, or somebody doesn't know it. I get to see some of these patients second time after they've already had surgery with someone else, and then now they come to me. And the things we have to watch out for are things like there's actually something causing pressure in the upper part of the brain, and it continues to force, the brain down. So this first surgeon may have done a great job of making room, but now the brain is being forced even lower and just reblocks that same spot. The other possibility is you have a leak of spinal fluid below, and that means that there's something sucking spinal fluid down, and that also sucks the brain down. And again, we were tight, we made space, and then we got stuck again. So it can happen. You can also see tethering, where the brain tissue sticks up against the dura, and so even though there was space, flow still can't get by. So there are a whole bunch of things. Fortunately, not common. Fortunately, I think we've just about got a solution to every single of the things that can happen, so that if something does happen where it should be, someone should be the unfortunate person to have it happen, chances are we can fix it. So the biggest thing about the recovery from Chiari surgery, I tell everyone, is, I think we do some of the smaller incisions that are out there, and definitely are the most careful about how the tissue is handled. Nonetheless, we're going right past all these neck muscles, and in order to do a small incision, we have to sort of pull this way and pull that way and pull up and down, because we're looking through a small opening to get all the work done in every direction. That's still nicer than having the big long incision and pulling everything, but it's definitely sore. So that's probably the number one thing, is some combination of just neck pain, headache, nausea, can be a real thing. And so while Chiari surgery by and large is not a particularly dangerous surgery, certainly it has risks, but the risks are, I'd say, generally quite low for brain surgery. The discomfort, especially in those first couple of days, can be there. And the number one reason why people stay in the hospital after surgery more than a day is just to get through that period of headache and nausea. One of the things that I really focused on from early on was making that incision smaller and being very friendly to the tissue. And that was just consistent with my overall surgical philosophy. It actually wasn't until some years later when I started having tons of Chiari patients, and I actually didn't know why they were coming. And the reason why they were coming, it turned out, that my patients told me, was because nowadays there are these communities of people who talk to each other about their experience. The patients themselves started posting their experience. They started posting pictures online of these little tiny incisions, of how good they felt after surgery. Well, up till then, people mostly weren't talking about how good they felt after surgery. They were talking about how bad they felt after surgery. And then, of course, for a lot of the patients, initially women, but then pretty soon everybody, they were happy they didn't have their head shaved. They were happy that they just, had their hair taken care of in a thoughtful way, that we tried to keep the incision out of their neck as much as possible. And so pretty soon the patients really voted with their feet. They were our best proponents. Actually, I'd never been on one of these sites. I only know that they exist from patients telling me. But many patients themselves, I'm grateful to say, told other people, yes, if you go here, this is how they do it. I'm glad that's what, that people who want that can find it. And that's what we do. The use of intraoperative ultrasound is something that's relatively new. It's certainly practiced, more and more over the years. But what that is an ultrasound probe is something that we can use during surgery to look inside at the decompression and see whether or not there's flow without actually opening the dura. So once we open the dura, we're pretty much committed to patching it, and that makes surgery longer. It exposes the brain to a little bit of blood and irritants. So if we don't have to do it, we don't want to do it. But luckily, we can go and not just guess, we can look. And so if there's good flow during surgery, usually when you're in surgery, you're in a prone position, so laying face down. And that's probably the worst for, how your symptoms are going to be, because it's almost like bearing down for the whole case. So if we see good flow, we're pretty confident that you're going to feel good after surgery, and we may not do the whole thing. If we don't see good flow, then it's probably not realistic to think that you will feel good, and so we go ahead and do the patch at that time.